Good evening, everyone. My name is Simran Chaudhary, and on behalf of Voice of Healthcare, I'm delighted to welcome you all to this critical and timely panel discussion titled Pollution and Pathogens: The Role of Affordable Diagnostics in Clean Air Healthcare, organized by Voice of Healthcare and supported by Kriyamed. Today, we have gathered here to address an intersectional challenge that impacts millions globally: the nexus of air pollution, infectious diseases, and the urgent need for accessible, cost-effective diagnostic solutions. As air pollution levels rise, so do the health risks associated with respiratory diseases, cardiovascular conditions, and infections triggered by compromised immunity. The role of diagnostics in detecting, monitoring, and managing these health threats cannot be overstated. However, affordability and accessibility remains significant barrier, particularly in remote regions. We are privileged to have with us the distinguished panel of experts who will bring deep insights from the diverse fields: healthcare, technology, public health, and policy, and diagnostics. Their experts will guide us towards the actionable solution and inspire the collective effort needed to tackle this pressing issue. So let us make this session a stepping stone towards a healthier, more sustainable future where diagnostic innovation plays a pivotal role in clean air and better healthcare outcomes for all. I would like to thank all my panelists today for joining in for this session, and I would like to introduce each one of them. Dr. Raksha K, consultant microbiologist and infection control officer at Manipal Hospital, Bangalore. Welcome to our show, ma'am.
Thank you so much.
Thank you, ma'am. Dr. Abdul Ghafur, consultant in infectious diseases, Apollo Hospital, Chennai. Welcome to our show, sir. Dr. Divya Joshi, associate consultant, infectious diseases, Fortis Hospital, Bangalore. Welcome to our show, ma'am.
Thank you. Thank you for the invite.
Thank you so much. And now, the other two speakers will be joining us in between. So we'll be starting us with a panel discussion today, starting with Dr. Raksha. Ma'am, does air pollution increase the burden of respiratory viruses like RSV and influenza? If so, what mechanism might explain this relationship?
I think we need to have a basic level of knowledge of these interactions between the environment and the pathogens per se. We, as doctors and physicians, know that currently antimicrobial resistance and all the new viral infections are on the rise. And also, in layman terms, if you say, we say, okay, now pollution is also more. We know that air pollution is a public health importance of problem, and there's a lot of cardiovascular and respiratory diseases that are coming up. But per se, in a patient, when you have to look at the interaction mechanisms, you already know that the pollutants are damaging the lungs. You have classification of these pollutants into gaseous pollutants, then organic pollutants, where you have your polycyclic aromatic hydrocarbons, then furans, aldrins, dioxins. You have heavy metals like lead, mercury, and the particulate matter, especially PM10, PM2.5, PM0.1. These are based on the size of those matter. Now, when they reach the lungs, what happens is already a inflammatory mechanism sets in. You have a hyperplasia of these cells. The epithelial cells get altered. The ciliary mechanisms get altered. A lot of oxidative stress already stress comes in into picture, and you have your inflammatory markers setting in like IL-6, TNF alpha. So an already damaged lung epithelium, and on over and above that, you have an infection setting in. It's like, setting your pitch for the runs, isn't it? So you have all your viral infections like influenza, respiratory syncytial virus, and of course your COVID, H1N1. So that sets the base for the infection. So air pollution is going to make it more complicated. make it more difficult for the physicians and the patients per se in terms of length of stay, the choice of antibiotics or antivirals, the diagnostic tests. It's going to add to the burden. So that is how it sets in.
Thank you so much, Dr. Raksha, for explaining us to this to all our audience. Moving on to my next question to Dr. Divya. Ma'am, are
Yeah.
specific clinical patterns or syndromes distinguishing pollution-triggered respiratory conditions from viral infections?
So yeah, we first need to understand two things. First is when we talk about viral infections, we have a whole spectrum of viruses which can cause respiratory infections. And these infections are mostly upper respiratory and in the recent times post COVID, and we've seen how it also extends to the lower respiratory tract, right? Which brings us to the hospital, probably we get admitted and so on. So when we're discussing about these respiratory viruses, the whole spectrum, there is influenza, para-influenza, influenza A, influenza B, respiratory syncytial viruses, metapneumoviruses, rhinoviruses, coronaviruses, COVID. So all of these spectrums initially are the ones which cause these respiratory viruses, right? As ma'am pointed out, Dr. Raksha, that how pollution can also create more damage and inflammation along with the respiratory viruses, and it can lead to further stay of the hospitalization, etc. So how do you differentiate the spectrum of illnesses between both the things? Usually with pollution, what happens is you have these particulate matters and then these harmful poisonous gases, for example, carbon monoxide, so nitrous dioxide and sulfur dioxide, etc. So these gases are the ones. So all those people who are already having a respiratory pathology like a chronic lung disease, so they end up having acute exacerbations of that, firstly. Secondly, it also produces an inflammatory milieu, an inflammatory state inside the lungs and the alveoli. So more the inflammation, the more damage it causes. The air exchange and the air entry, etc., is also hampered. So this is what happens usually when we are discussing things pertaining to the pollution. Coming to the respiratory viruses includes the spectrum in which we have the upper respiratory. So the syndromes were characterized by coryza, which is running nose, dry cough, fever, body ache, malaise, etc. Following that, now it is also percolating into the lower respiratory tract. So you have productive sputum, cough, at the same time breathing difficulty, wheezing, bronchiolitis, etc. So that is how you can actually differentiate. But now the spectrum that we're discussing about how pollution and pathogens are playing a role, how together it is causing more inflammation and damage, which is what is worrying right now. And yeah, that is the thing. Thank you.
Thank you so much, ma'am, for clarifying that. And I think that is actually very necessary to distinguish between what is causing what. Moving on to my next question to Dr. Abdul. So, air pollution as a triggerer. Can air pollution exacerbate existing respiratory viral infections such as RSV or influenza? If yes, how it affects disease severity and outcomes?
Right, Simran, that's an excellent question. Air pollution increases the chance of virus infections, and virus infections are worsened by the presence of air pollution induced lung changes. Divya very rightly explained and very nicely explained. Air pollution alters the respiratory epithelial integrity. It reduces the so-called mucociliary clearance. It enhances the viral penetration into the respiratory system. And not only that, air pollution reduces the immunity. It reduces the macrophage function, T cell function, increased inflammatory cytokines. All these are the perfect environment for the virus to multiply further. In fact, there are enough experimental evidence which has proven that air pollution increases the viral multiplication of influenza virus. That means air pollution increases your chance of getting a respiratory virus. When you get a respiratory virus, that's severe respiratory virus infection because the viral multiplication is more, and because of reduced immunity, viral clearance is less. So the chance of getting an infection is more, and if you get, it's going to be more severe and more prolonged because the viral clearance is delayed. So it's a vicious cycle. Air pollution and virus infection is a vicious cycle. One help the other. And even the environment, we know that cold weather itself increases chance of virus infection for so many physical reasons. That's why in cold countries or any countries, cold weather November, December, January, more flu in Western countries and some part of the cold countries, where there will be increased persistence of the virus, and air pollution adds to this persistence of the virus. It's all by proven data. Cold weather increases the virus infection chance, and the air pollution increases that potential further. This is proven by epidemiological studies, clinical studies, and animal experimental studies. There's a data from China, if my memory published in around 2017. Environmental pollution increases the chance of virus infection. Data from China, data from Korea, and there is other published data that air pollution increases the mortality, death rate due to respiratory infection in population. So we have got epidemiological data, clinical data, experimental data that air pollution increases the chance of virus infection, severity of virus infection, increasing the morbidity, increasing the mortality due to virus infection.
Thank you so much, Dr. Abdul, for explaining us that. And that knowledge, that awareness is actually very important. So to understand about the air around us, the pollution around us, and the pathogens, how it is harmfully affecting us. With that, I have just saw that Dr. Soumyadeep sir has joined us. So I would like to introduce him. So welcome to our show, Dr. Soumyadeep Chatterjee. If we can if you can switch on your camera, so that would be great. So
Hi. Thank you for inviting me. Thank you, sir, for inviting me here.
thank you so much, sir. By introducing you, Dr. Soumyadeep Chatterjee is the consultant of Department of Infectious Diseases at Tata Medical Center, Kolkata. Welcome to our show, sir. So, my question to you is, like Dr. Abdul just explained us about the harmful effects of the air pollution, the pathogens, and how it is affecting us. So, like Sir said, RSV and influenza are particularly harmful to the vulnerable pollution, including the children and the elderly. So, does air pollution worsen the outcomes for these groups, and how should clinician approach such cases when they're treating them?
See, as Dr. Divya was explaining the pathophysiology of why and how air pollution increases chances of viral infection and how it affects the immunity of the local immunity of the respiratory tract, and as Sir was saying, how air pollution and cold weather predisposes to infection. Yes, so the outcome worsens in the sense that the symptoms often linger. It is a very common presentation that a person suffering from viral respiratory tract infection keeps on coming back to our clinic saying there's persistence of cough that goes on because the inflammation together that happens keeps on some inflammatory airway disease. RSV is specifically known to cause reactive airway disease, and especially in children, it can cause complications as bronchial asthma. So these are the common complications that keep on happening post-viral infection, post-viral cough, and post-viral reactive airway diseases are most common, and they are very much bothering, increases morbidity, and in immunocompromised patients, I mean, air just keeps on adding to it because it also causes a lot of allergic reaction, a lot of inflammation that goes on. So it exacerbates the inflammation that the viral respiratory tract viral infection has given, and instead of letting it settle, it just worsens it. So definitely air pollution and air quality, backward air quality leads to worse outcomes with prolonged morbidity in patients suffering from viral respiratory tract infection.
Thank you, sir, for explaining us to that. Moving on to my next question to Dr. Divya. Ma'am, have you observed an increase in the burden of RSV infection in the recent years? And could air pollution be playing a role in this trend?
Yeah, hi. So I think post-COVID, we have started realizing that, viruses are deadly And I think everybody has started understanding the fact that screening for viruses, they want to know what virus you have. So there are two reasons why there is definitely a surge of RSV cases, and I think there are two specific reasons which I can think of. The first being is improved diagnostic modalities. So we've started screening for a lot of respiratory viruses, not just COVID, not just corona, but we have a panel with PCR panels, I think, which will be discussed later on, so which actually picks up what respiratory viruses you've got. So basically, because of this, we've seen a surge of the cases also. And I think secondly, what I would like to point out is, yes, there has been a recent increase, and we have found out that a lot of RSV cases have been there. I don't know how we can point out saying that no, air pollution is the cause for an increase in the cases. What I believe is there have been these respiratory syncytial viruses will be present in the environment, and because of there are antigenic drifts and shifts in the viruses, etc. And so you will always have the strains which will become more powerful, and then they'll start harboring and then causing infections. So which is why we've started a lot of these infections because of the altered inflammation. But yes, air pollution definitely has worsened the ability of the virus to remain, cause, as Dr. Samvideep sir also pointed out, how it causes prolonged bronchitis, bronchiolitis, reactive airway diseases, etc. So first is because of COVID, we have started our heightened antennas to catch up all of these respiratory viruses have already been there into existence. Secondly, the diagnostic modalities have improved, which is why we are having an area of all of these tests. Like in my hospital, we have a flu PCR, which only picks up influenza A, B, and RSV specifically. So they have only a lesser cost of all these modalities. So it actually, so that is why we have seen a lot of respiratory syncytial viruses, because we have started picking them up. Our PCRs have started picking them up, and we have included this in a routine screening method also for all of them who come with these infections. So that is second. And third, with, as you rightly pointed out, because of the worsening air pollutions, etc., with the more inflammatory responses, that has also been one of the factors. It's actually a multifactorial cause which has seen a rise in these cases, partly because of existence, and we are able to find out more now, and secondly because of these air pollutions, etc., which has caused it. So yeah.
And why we are putting this air pollution into the frame is because, as a layman, if I have to, the basic understanding around this is there's so much of industrial waste, the thermal power
True.
plant waste, the stubble burning, and many
True.
other, waste which is coming out of the vehicles and everything. Those
True.
those harmful chemicals are maybe somewhere adding to the pollution. So let's say the severity, like you said, it has
Absolutely.
worsened, right? So I think
Absolutely.
that's how it has increased the risk of having such cases
You're much
more
more
nowadays.
vulnerable of getting it. Yeah. So initially the immunity would be better. Now you're actually much more vulnerable because you're all having these reactive airway diseases. How many people are having these chronic obstructives and interstitial lung diseases, or reactive, just normal airway diseases, have also increased. And nowadays we're seeing these viruses also causing these inflammatory responses. You know, we have a post-viral bronchitis which is lasting for a longer duration of time than we saw in the routine cases before. So yeah.
Yeah, and like you said, post-COVID, our respiratory has become more prone to catch more such kind of infection. And let's
Absolutely.
not forget the post-Diwali scenes where the
Oh
pollution
yeah,
is all around the air. So,
that's true.
moving on to my next question to Dr. Raksha. Raksha, ma'am, how does RSV in adults differ from the presentation in children, particularly in areas with the high pollution levels?
See, when we talk about these infections, specifically, say RSV or influenza or any kind of viruses, COVID, H1N1, first thing is when we look at the symptom differences as such, we know that these are all lower respiratory tract infections, and the symptoms as such would be your fever, cough, and once it reaches the lower respiratory tract, you will have pneumonia and features of say even it if secondary bacterial infections also after that. Adults per se, what we see is above the age of 60 or say even 75, we do see pneumonia cases with, like how Dr. Divya mentioned, we do send for flu panels like this with influenza and RSV. Of late, we have been seeing cases of, in the winter season, influenza and RSV more common. Children per se, what we see is again when we only test as per the flu panel, we tend to detect it. So more so, it just gets identified as a ILI or pneumonia case, and the diagnostics as such is not very strong in our country to say that okay, this is an RSV case or this is an influenza case. I'm very sure the ID physicians would agree. Unless you do a flu panel testing, no, I don't think you're going to differentiate it that way. The only way to go forward is to have your testing mechanisms, use your PCRs in place to uh, detect these viruses. As such, I have not personally seen anybody asking for any clinician, me as a microbiologist, specifically asking for tests to identify influenza, RSV, unless you are in a tertiary care center. I don't think the test modalities are now existent currently in all hospitals to differentiate these flu-like illnesses. The other ID physicians can probably add to this. What is their experience with regards to this?
Thank you, ma'am, for answering my question. My next question is to Dr. Abdul. Sir, diagnosing RSV has traditionally been overlooked in adults. So, should affordable PCR testing change our approach to RSV diagnostics in pediatric and adult patients as well?
Yeah, Simran, that's a very good question. I'm an adult infectious disease physician, and in my practice, until recently, the detection of RSV or the number of patients I treat RSV were very few. In fact, most of my patients are cancer patients, and that's when the RSV produces severe pneumonia and even death. But even then, we are not testing every patient with cough and cold for RSV because the testing was expensive. If you do a multiplex panel that detects 10 or 12 viruses or bacteria, it's very expensive. Many people can't afford. Even my so-called, I work in a corporate private hospital. Even not all my patients can afford expensive respiratory PCRs. But when we have a low cost, affordable, accessible PCR system, then we do more testing. And the more you test, the more you identify. The more you identify, the more you treat. Of late, because we have an affordable multiplex PCR that detects COVID, RSV, and flu. And I'm testing more and more patients, my cancer patients, for respiratory viruses. And you will be surprised. I'm identifying more and more RSV in my oncology patients, and I'm treating more and more RSV because my oncology patients, once I detect RSV, especially with moderate symptoms, I had to treat. I start ribavirin. And some of my patients with severe pneumonia, I've given even immunoglobulin, ribavirin with immunoglobulin. So, if you want to treat these patients, you need to identify. If you need to identify, you need to have an accessible, affordable diagnostic test, PCR diagnostic test, multiplex PCR diagnostic test. Not only you can treat the patient, reducing the morbidity and mortality, you can even reduce outbreak in the hospital. If you don't test, you will miss. If you don't identify, that virus, RSV, flu, or COVID is going to spread to other cancer patients or any hospital, any other children, other patients in the ICU. It's going to create outbreak. And that's going to increase the burden on patients and the hospital. So we need affordable, accessible, rapid diagnostic test. And that will improve the outcome of the patients, reduce the number of infections in the hospital especially, and even in the community. People say, okay, in if you why do we need a testing? Just give oseltamivir. But now we know that when you test, not all of them are flu. Some of them are RSV, some of them are other viruses. And if you give right and left oseltamivir, that will be overuse of a very precious antiviral,
Yes.
creating antiviral oseltamivir resistance. If, for example,
Hmm.
in area polluted air, the respiratory symptoms of pollution are almost very similar to that of infection. Of course, there are some clinical differentiating features. None of them are very accurate, but there's an overlap between the syndrome of pollution and infection. And infection itself could be any number of infection, or it could be pollution infection together. So it's very important to differentiate pollution alone with infection. And if infection, ward infection, that will reduce the unnecessary antibiotic usage, that can help us to treat the patient with the proper antiviral, because COVID has treatment, RSV has treatment, flu has treatment. We need to look for the preventable and treatable viruses like COVID, RSV, and flu, identify them early. But again, I stress affordability is the key. Because Raksha mentioned people cannot afford this test. But when we have affordable test for a LMIC country like India, affordability is very important. Thank you.
Thank you, sir. You rightly pointed out affordable testing is very important. Like you also mentioned about that RSV is treatable, COVID is treatable, any of the infection is treatable. But then if we have the treatment of all those things, we need the testing as well. And more testing will move us towards the treatment of all these infectious RSV or the COVID. So I think that is the more focused. We need to stress more on that. We'll discuss on that later. But moving on to my next question with Dr. Somadi. So, with the recent availability of RSV vaccines, how should clinicians prioritize their use, especially in high risk population? And should areas with high air pollution also be a priority? And like Dr. Abdul mentioned, more of antibiotic medicines are being given to treat any of these kind of infections, and that is making people more of AMR resistance. So how can we consider everything at the same point of time and make such treatment options more impactable?
Okay, so that's a very important question. So the question that we need to answer is, why do we not get vaccines or medicines in India which are new to the world? So when you are asking the question, we don't have access to RSV vaccine in India. And the RSV vaccine that has been licensed, there are three vaccines. One is adjuvanted recombinant, one is without adjuvant, and one is mRNA vaccine. These vaccines they have been launched for elderly population, those above 60 years of age, and some of them are also licensed for use in pregnant patients. Having said that, this don't apply currently to our country because we don't have access to them, and that is very common. We didn't have access to the latest COVID vaccines. We don't have access to the latest antibiotics that we have. So we keep on suffering. So this is where the policymakers need to take a call. Why are these things delayed in India? Because I don't think, I mean, the kind of pollution that we see in being a developing nation, this is seen by the Western world. So having accepted that viral infections are more, or they are more common in populations who are more exposed to pollution, and their morbidity is more in such population, we should have access to these vaccines. If these are available, then according to the data that comes up with these vaccines, it should be appropriately used, especially in high risk groups. So it is applicable to pregnant patients, which actually passes on to the immunity to the newborn and the infants. And these vulnerable adult population, they are more prone to severe respiratory tract infection and death. So rightly, in such population, this vaccine should be used, because it with more passage of more time, we are getting more data that these vaccines are effective. But currently, they are not available in India.
Thank you, sir, for highlighting this very important point that the vaccines for RSV is not available in India, and and like you said, this is not the first case. India is a developing nation, and let's. I believe that it's not the first country who is facing this kind of a problem where the country is in its development phase and facing all these pollutions. I'm not accurate about the year or something, but I believe Britain in their 1800 or somewhere also faced such kind of bad air pollution where the visibility was so bad, and hospitals were full because of the infections and everything because of the air pollution. But then the government intervened and they put up a ban on some of the industries and control to curb this pollutions as much as they can. So I think that is also more required, that the government is actually trying to put some of these and intervening in for Delhi NCR regions, more of that. But I think we need to be more cautious on that. So that's the government parts, and I believe they'll be doing something more on that. Now I would like to welcome Dr. Neha Gupta to our show. Welcome to our show, ma'am. Uh,
Hi.
Hello, ma'am.
Thank you so much for having me here. Thank you.
Thank you, ma'am, and thank you so much for coming to our show. Let me introduce you. So, Dr. Neha Gupta is a senior infectious disease physician at Fortis Gurugram. And my question to you will be, what evidence links air pollution to an increased burden or severity of influenza infections?
So, see, whenever there's air pollution, it will result in an increase in the allergic reaction or the inflammation in the airways. And whenever there is inflammation in the airways, that will be associated with increased risk of infections. And clinically, also, we have seen there is whenever there's an increase in the air pollution or the AQI levels in the Delhi NCR, we are seeing a surge of infections which are resulting in upper respiratory tract. The patients develop viral fever and cough, cold. All this has been on a rise.
Thank you, ma'am, for answering that question. Moving on to my next question to Dr. Divya. Dr. Divya, does air pollution potentially weakens the efficacy of flu vaccines, or predispose vaccinated individual to more severe infections?
So the first part of the question where you say that what is the effect of pollution on the vaccine? I would like to phrase it, or I would like to say it in this way, that vaccine has actually helped in decreasing the severity of the flu, as well as also helped in pertaining to, along with, when you have an air pollution into the picture, along with these viruses, vaccines have actually played a role in decreasing the morbidity, length of the stay, etc. So that way it helps. Secondly, when you have asked about the severity of the disease, what happens with the severity of the disease is that, as everybody has rightly pointed out, that there is an inflammatory milieu. There is a lot of inflammation going on, and on top of it, when you're having a respiratory viruses percolating into the lower respiratory zones, that point of time when there is an increased oxygen requirement, etc. So air pollution is contributing to the severity of the illness in these cases. So that is what I would like to point out over here, that vaccines as such helps in decreasing the severity of the illness when you're subjected to a flu virus. But at the same time, along with the air pollution into the picture, along with the vaccines, we're seeing more and more cases in which we've gone to the severity. Thank you.
Thank you, ma'am. Thank you so much for answering that question. Moving on to my next question to Dr. Raksha. Ma'am, despite the availability of flu vaccines, their uptake remains low in many parts of India. And how can clinicians use diagnostic testing to advocate for greater vaccine uptake?
Yeah, thank you for that question. So, when we talk about immunization as such, in terms of adult immunization and the availability of these vaccines, we do see adult immunization clinics with strong advocacy for these kind of vaccines in, say, immunocompromised patients, transplant patients, or say tertiary care centers where you have infectious disease physicians who are kind of advocating for this. But at the grassroots level, if you have to look at the availability of these vaccines at government centers or say primary health centers, and the knowledge about it as such, even amongst the physicians, is something which is not helping us in the scenario of advocating these vaccines. Of course, there are efforts made. Recently, I was just reading up after this webinar topic came up, that just last week in US they had a published data from the advisory committee on immunization practices from CDC. They said only about 31% of their population was vaccinated with RSV, although it was available. And in terms of influenza, it was about 70%, even though they were available in the centers. So I think awareness is the key in this aspect, and also accessibility in terms of incorporating this in your health checkups, educating your patients when they come for other illnesses, and also during peak seasons. Like we know that influenza vaccine, every 6 months it is advocated, and making this more affordable for your patients, and that is the key. And also, like Dr. Soumyadeep mentioned, what is the scenario in terms of policy making including this in your immunization schedule as such. The IAP guidelines do not recommend it yet in India, although CDC does recommend for elderly population above 75 years and at least one dose of RSV for lifetime. These kind of guidelines are not there yet in India. So I think it all starts from there, and we need to incorporate in terms of our guidelines, then ensure that these vaccines are there firstly in our country, and then comes the affordability and accessibility for patients.
Yeah. So I have a to build upon what Dr. Raksha has also mentioned. Of course, diagnostics are extremely important, but as a clinician, what I feel is making a difference in my practice is also when I make a diagnosis of a person who's coming with, say, URTI, cough, cold. So instead of just writing viral, we also write that, probable influenza. And with that, there is a curiosity among the patients that what is influenza and how can we prevent it. So maybe, to begin with, just to mentioning a clinical diagnosis and of course, to establish it with the molecular assays or the other diagnostic methods will definitely help in increasing awareness as well as subsequent uptake among the patients.
Thank you so much, ma'am, for putting up your views on that as a clinician. And thank you so much, Dr. Raksha, for explaining us this question to us and to all our audience in a very layman language. Moving on to my next question to Dr. Soumyadeep. So, during this flu season, how often do you see patients co-infected with RSV and influenza? And what diagnostic strategies should clinicians use to identify and manage these cases?
That's a good question. Well, I just as Ghafur sir, I also work in a cancer center, so with a lot of bone marrow transplants and leukemia patients around. So yes, so this concept of co-infection in India has come up only with COVID. So this is one of the pros of the COVID pandemic, that we all have access to nucleic acid based testing. Now, I mean, just as the various literature says, the co-infection rate ranges from between 20 to 40%. We see similar incidents in the influenza season here as well. But since this is a new concept, we are just now about looking at our data. In another 6 months' time, we would be able to tell you exactly how much co-infection we saw in the past 3 years after COVID. But yes, this is what we see. And as sir was telling, that these two viruses actually have treatment, in especially in immunocompromised patients, especially after transplant. We do use ribavirin to treat RSV, and influenza has its treatment. Testing in centers like ours with a multiplex PCR is required, because we have patients who may benefit and otherwise patients might worsen. This is on one hand. On the other hand, having seeing it like in a generalized manner, you would find, unless these are tested, most of them are treated only for flu. Many of them do not have flu, and they get oseltamivir with unnecessarily. So this has implications, because again, the only antiviral against flu that we have access to is oseltamivir. We don't have access to anything else, and the armamentarium is also limited. So this is an advantage, I mean disadvantage, and therefore we should use judiciously wherever possible the multiplex PCR. But having said that, the cost remains very high. One of the companies, even at a subsidized rate in our hospital, it would cost around 10,000. The other company that we routinely use, it costs around 6,000 rupees. We keep very minimum profit margin, being a non-profit organization. But any corporate would keep a profit margin and sell it at a very high rate, which is impossible for common man to get it tested whenever that person has respiratory infections. Now, any immunocompromised patient will have recurrent respiratory tract infections. So how many times in a year does a person test with a 10,000 rupees or 15,000 rupees test? We have an alternative of a 4 viral panel that we often use, that includes influenza, RSV, metapneumovirus, and adenovirus. So we do use, but even that costs around 3-4 thousand rupees in our hospital. So unless we as a society, as a country, have a policy of, because see, we have seen that in COVID, that this nucleic acid amplification based tests were actually capped. The market prices were capped, and at the end of the pandemic, towards the end of the pandemic, we had done testing with PCR at just 500 rupees because government had mandated it. So if that was possible during COVID, and when we know such a lot of people in our country suffer from respiratory illnesses, which are increasing with time, why can't we come up with a policy which subsidizes or caps the price of such multiplex PCRs or PCRs that are available?
Hmm. Yeah. I think so. You rightly pointed out, and I think this also was brought up by Dr. Raksha. Ma'am, and now we'll be focusing on the affordable diagnostics. So, Dr. Raksha, my question to you is, RSV and influenza are treatable or preventable, but their diagnosis is often missed due to the cost concern. So, how do affordable PCR tests could transform this landscape in India?
Firstly, what I would like to tell is this misconception that PCR tests are costly and not affordable. I think we as physicians have to change that, because when you look at long term implications of these tests, one thing is these are molecular tests with high sensitivity and specificity. So once you detect or not detect, at least if it is not there, you rule out. And so also you make the right choice of treatment, not you do not misuse or overuse the antibiotics, which again is another cost factor and is going to burden the patient. So you're going to cut down on that. Second thing is your turnaround time for these tests. And many of these panels are on automated PCR machines now, which are there in the labs, and they can be done in a matter of say 2 to 4 hours, depending on the platform they are using. So turnaround time is not the problem here. If enough machines and enough centers are having all these testing equipments and modalities, and if with multiplex PCRs, you can of course detect the other pathogens. Like Sir said, it could be a co-infection. You can have a secondary bacterial infection also there along with the viral infection. So once the diagnostics is right, you know
Hmm.
that the treatment also can fall in line, and there comes your cost effectiveness. The patient's diagnosis is clear, and then the hospitalization reduces, the unnecessary treatment reduces, and the number of beds that are occupied in the hospital, the length of hospital stay is cut down. And if you look at the larger picture of the hospital per se, the economics, it is going to benefit the hospital and the public health. One suggestion, like Dr. Soumyadeep mentioned, is to integrate these tests in your surveillance system itself. Already, we have an influenza surveillance which is at a national scale. So, if these tests are made available and capped at a certain price, and doctors can use it at various centers to diagnose. Just to cite an example, say in Bangalore, the dengue tests are capped at 250 for a ELISA test, and the rapid immunochromatography card is 300 rupees. So we know, and they have advocated not to use these immunochromatography cards. So a policy decision has to be made at that level, and all the hospitals will be equipped to use these tests so that diagnostics becomes more accessible for the clinicians. Right now, we do have these tests only in certain centers, and the cost is a factor for patients. They cannot simply afford to pay for these tests. So the scalability and accessibility has to be improved at that level in terms of diagnostics and integrating it with the public health programs. And more so, this has to be a point of care diagnostics. I have to quote Dr. Rajiv Soman in this regard. We recently had our microbiology national conference. Sir mentioned a very beautiful thing. The costliest treatment is the antibiotic that doesn't work. Believe me, many of these patients who are actually viral infections, not detected initially, worsen after about a stay of 5 to 7 days in the hospital, develop a MDR, Klebsiella pneumonia, ventilator associated pneumonia, and stay in the hospital for another 2 to 3 weeks, which is going to add to the finances. And it's just Another pandemic per se which you're dealing with, antimicrobial resistance. So you just open a Pandora's box with not diagnosing it at the right time. So I think all these needs to be addressed at a policy level, and there needs to be an integrated system for diagnostics and treatment.
You
I
said it
just want
right,
to add
ma'am. And
to what ma'am actually told just now, and it's very true that from the public health point of view or from the hospital epidemiological point of view, and from the AMR point of view, we do test patients. We need to test patients. These tests are all for the benefit of the society. But having said that, when we are dealing with individual patients, I think everyone in the house would agree that it's often very difficult to order a test which costs more than 10,000 rupees for a common cold. It's very
absolutely.
difficult. And surveillance will never serve the purpose, because when you are doing surveillance, you are appointing certain centers to do the test free of cost. This needs to go out just as COVID PCRs were rolled out with price capping. That is the only answer to this. At least, as I was telling, there are tests available for 4 viruses: influenza, RSV, metapneumo, and adeno, that goes out, and 3 of the viruses have some sort of a treatment. Metapneumo is something of a very mild nature mostly. So if we can have a policy, because see, as we all agreed, it affects the AMR, it affects the health of the population, it affects the health of the young generation, and it affects the health of the nation. So this is very important that there is a policy decision, because having interacted with the industries, we all would agree that we know how huge margins they have, because they do reduce the cost in the face of competition when similar PCRs are launched by other companies. So that means there is ample scope of reduction of cost. And once the government caps it, they would reduce it.
So, like
Right.
you and ma'am rightly
Yes.
pointed out, it should be rolled out like the COVID PCR testing was being done when the COVID was there, and I think most of the people have done that free of the cost. So just to get exactly the diagnosing ki ho kya raha hai exactly, we need to have that testing at a mass level. Abdul, so you
I
were
can
saying
add
something?
something. I completely agree with the arguments Saumedhi made and Raksha added to it. We need affordable diagnostic. Most
Absolutely.
people can't afford a respiratory diagnostic that costs 10,000 rupees. What we learned from COVID, and somebody stressed that point. And I also remember when we introduced the COVID PCR, I remember some hospitals started charging 16,000 rupees, became 10,000, became 6,000, became 5,000, became 1,000, became 400, because government capped the price and brought down the price still further. Today, COVID PCR is one of the lowest cost tests available in the country, probably as cheap as affordable as a complete blood count CBC. That because of the huge margin of these PCRs, and that is exactly happening in respiratory multiplex PCR. We need PCRs that cost less than 2,000, less than 1,000, and such PCRs are available. Recently, we introduced one that's from an Indian firm that costs, and even at Apollo, we are charging less than 2,000. And to my knowledge, it can be, we can charge even 1,000 or even less than that because of the margin of the test. That's why it's 10,000. We can bring it down. One way is capping the price. Other way is encouraging uh, our own indigenous test, which is validated test, and that is low price because our people cannot afford expensive tests. So this is the way forward. We do have low cost tests available in the country, and we can use it. Very affordable multiplex COVID, RSV, flu is available in the country. We recently introduced it in our own hospital 2 months ago. That's why I'm able to do more and more respiratory PCR and detecting more and more flu, more and more RSV, and able to treat more and more. And I'm able to do infection control in a better way.
So
To
that
that,
is
sir,
that
I
is
would just also add, whenever we are encouraging the indigenous tests, recently there is an Indian company who launched a tropical fever panel. So my experience with that test is not very good, though I don't personally prefer doing a PCR which costs around 6,000 rupees to diagnose a fever of a poor man. It's a tropical fever. But having said that, I get referrals with reports of that PCR. It's horrible.
Hmm.
So we need to check the quality as well. So that is where it is important. I mean, while it's important that we cap the price and we encourage the indigenous product, which would reduce the price definitely, but we'll have to have check on the quality with integrity, because all our QCs don't have integrity, as we would all probably agree.
Agree, Samiti, that's a
I
very
think
valid point. That's a very valid point. But we do have ICMR validated with the test validated multiple centers with proper available quality control multiplex PCR available in the country, and we started using it in our own. Apart from ICMR validation, we validated in our own center, and we have started using in all our centers now.
That's important. That's important to validate in-house and be confident about it.
Because the Indian companies have the capability, because we have the one of the best molecular biologists in the country. We have companies who can develop. We have got Molbio. We have got so many other companies. We know the TB
Absolutely.
diagnostic.
Yes.
We revolutionize the Indian companies.
Yes.
Revolutionize the TB diagnostic by providing
Yes.
affordable, accurate. Similarly, even for respiratory viruses, we have to have validated Indian companies recently made available with ICMR validation and SIPSCO approval.
We
absolutely
have
the
all.
cost of
So, ma'am, you were saying.
Yeah. So definitely the cost of the test has to be much lower than the cost of the medicine. If it's there is too much of difference, then the patient may say, "Oh, I will take the medicine. I will not do the test." So the test has to be more affordable and convenient for the for us clinicians to order as well. If we order also a very expensive test, there is in a private OPD uh, for people who are not working in institutes or having their individual OPDs. There is also they will think that, oh, will the patient come back to me again or not, because then they will have this that doctor has written such an expensive test for just common flu. So we really need to have affordable diagnostics for make
Yeah.
that will for
Yeah,
arriving at a particular etiology.
I do know that
that's
Neha perfectly agree with you, and it should be low cost. And and to my knowledge, there is Indian multiplex PCR which can be even done at 800 rupees. The same thing that's 2,000 can even be done at 800 or 900 rupees or less than 1,000 rupees. But if you ask me whether I want oseltamivir or spending 1,000 rupees, I spend 1,000 rupees because I hate oseltamivir. I hate the taste of oseltamivir. I took only one tablet oseltamivir in my life, produced gastritis. I hate that one.
Sir, but asking to spend 1,000 isn't the case. It's asking to spend 5,000 or maybe 10,000. So in the, in that case, they love taking oseltamivir. That's the whole issue. The OPD it becomes very, very difficult when you expect somebody comes to you, as rightly pointed out, with everybody that, with somebody is coming with fever, cough, cold, influenza-like illness, and then you say, no, no, you get a test. Let's identify what it is, which is the rightful thing to do in terms of AMR and antiviral resistance, which is propagating. But at the same time, expecting the person to agree to the test that you're doing is a very big thing. The justification only happens in an inpatient setup when you're having sort of a viral pneumonia kind of a picture in those situations, unfortunately, with
Right,
the
right,
cost aspect here.
right.
I think we all agree with this point that the diagnostic test should needs to be very affordable, so that even if the clinician writes down there, even the doctors wants to do all those testing to their patients, so that they can proceed further with their treatment. It should be affordable. They should not be thinking twice or thrice for that. And like Abdul sir said, and Dr. Soumyadeep sir said that it's somewhere around it is available in this kind of costing in their institute or circulated by a few of the organizations, the government organizations. But it is just limited to few of the places. To get this reach to the masses, it needs to come from the government. And like we all have seen the scenario where we all mentioned about this COVID testing. It was very cheap. Like Abdul sir mentioned, it was in hundreds, right? So that can be done. We have a great organization. We have such great microbiologists around there, researchers, the organizations who are working and you know making or becoming the examples during the COVID. Like India was one of it. We are capable of all such things. But let's move on to our discussion. My question is to Dr. Abdul. So, how effective is syndromic testing in differentiating between RSV, influenza, and other respiratory viruses, especially in patients with overlapping symptoms from the pollution related syndromes?
As a clinician, it's very difficult to differentiate between pollution induced respiratory syndrome and infection related. Yes, I can enumerate at different points of how you can differentiate, but that's not always easy. Yeah, but still, for the purpose of the discussion, a pollution induced, usually starts when you're exposed to the pollution and usually disappears if you move out of the pollution. And as long as you're exposed to pollution, your symptoms may persist. Unlike a virus infection, usually lasts around 5 to 10 days, usually 7 days. And there are few changes, your differences where you can do differentiate during clinical examination and the markers, but all of them are non-specific. If you're really in doubt, and as clinician, I am in doubt quite a number of patients where, oh, this is only pollution induced, or if it's a virus infection, if it's virus, is it COVID, is it flu, it's an RSV. Especially my oncology patient with altered immunity, it's very difficult for me to differentiate. And when I am in doubt, my only way of differentiating is testing, because pollution and infection coexist and virus infection themselves coexist. So in this very complex scenario, my sure shot of differentiating is test it. As long as I got an affordable, accessible diagnostic, my best way is test it. And if I test it, I will know, is it COVID, is it flu, or RSV. Otherwise, I will be giving all my patients unnecessary oseltamivir, a very dangerous practice of unnecessary prescribing oseltamivir to everybody. Especially with such an overuse, we are going to lose the potency of the only available antiviral. The only available anti-flu agent commonly used is oseltamivir. If this is the way, we will lose that drug in near future.
Thank you, sir. Thank you, Dr. Ghafur, for answering that question. Moving on to my next question, Dr. Divya. Although, ma'am, we all have discussed about this aspect, the affordability of the testing, but I would still like to know the cost benefit analysis of these testing. So, how would you justify the cost of routine testing to RSV and influenza using affordable PCR diagnostics to healthcare providers in resource constrained settings?
I think this is a summarization of whatever we've discussed in the last 10 to 15 minutes. So I'm just going to point 5 points and discuss it. In the OPD settings, when the patient comes to you with fever, cough, cold, it is better that we know what virus it is, because it's justifiable in terms of an antiviral resistance that we'll be propagating. Firstly, that. But at the same time, the cost needs to be brought down, and expecting somebody to do a PCR-based current setup, in the current setup, expecting somebody to do a PCR test will be a long shot, because I think, as we rightly discussed, a lot of patients would not agree to doing that. Second justification comes as inpatient setup. When I'm looking at the inpatient setup and somebody comes and is presenting with a pneumonia, suspecting like a viral pneumonia, and probably in the current setup propagating to, as we saw in COVID, and later on, as we have seen right now, especially most commonly in children, how respiratory syncytial viruses have caused acute exacerbations and bronchiolitis, etc. And with metapneumovirus also, we saw increase in the viral pneumonia in the last couple of years. That time it becomes justifiable to do a multiplex PCR. And if that multiplex PCR turns out to be a little expensive, as I think Dr. Samvedip sir rightly pointed out, how you can have 4 or 3 different PCR virus panels which it can pick up. So that way it becomes more affordable, better, and justifiable, because 3 out of 4, as he pointed out, has implications in terms of we do have antiviral that we can act against in those cases. And especially another setup where it becomes absolutely justifiable, as Dr. Ghafur sir pointed out, is in an immunocompromised setup, because in those situations, the viral clearance takes a lot of time. So it's very, very difficult, because the virus stays in your respiratory tract, and it is very, very difficult to clear that virus out. In those cases, there is a continuous response which keeps on happening, and it is extremely important to treat those viruses. As we saw in COVID also, the virus stayed for more than probably even 5 to 6 months, with seen positive values that was happening. So in those situations, in immunocompromised setup, bone marrow transplant, renal transplant, etc., in all of these patients, it is extremely important to understand in these setups that how to treat them is important, and that is where it becomes extremely important. The diagnostics plays an important role, especially PCR. But having said this, it's also important to cap these prices, and I think that's how I would like to conclude. I think everybody has pointed the same thing out. So yeah.
Yes, ma'am, you rightly concluded on that. My last question to Dr. Neha on the different aspect, that is the broader clinical and public health implication. Ma'am, have changes in global air quality and pollution level contributed to a rise in RSV and influenza cases? So, if yes, what public health measures should be considered to, curb this?
We lost Dr.
Dr.
Neha.
Oh, I think we got her connection out. Not a problem. Dr. Raksha, would you like to answer this?
Sure. I was just listening to everybody, and one thing which I thought was missing here was the large amount of data that we are getting out of all this, the diagnostics, the testing. On a larger scale, when you see the patients that are being treated in individual hospitals, of course we have an influenza surveillance system. We are talking about RSV, we are getting cases in our own hospitals, but where is the Indian data? And also to link it with your air pollution indices, like studies that have happened in western countries, we are just drawing parallel with that. Probably we as individual institutions can take this up and see what is the scenario here in India? What is our current data? So when your policymakers are going to ask you with what basis do you want us to introduce these vaccines, where is the data? So when you talk about public health management, I think these kind of interdepartmental collaborations at higher level should happen. Probably the pollution control board and the Ministry of Health and Family Welfare can look at how air pollution is affecting these viral infections per se on a larger scale at a national level. So, yeah, public health policies start with that kind of research. So, to get vaccines in place, to ensure that these diagnostic tests come into the forefront in your guidelines and algorithms for diagnostics, I think that kind of research is also needed, and we as physicians should be doing that along with our clinical care. So that is one input which I would like to add with the current discussion that we are having. I think that is something which we are greatly missing in India.
You
Although we
rightly
have
pointed
amount of data, it's not,
out.
Yeah.
Yes, thank
Thank you,
you.
sir.
So,
Can I to add to what
yes,
Raksha mentioned
yes.
again? Raksha made a very valid point. 2 days ago, I was participating in another panel discussion on behalf of AMR Trust, the role of vaccine in tackling AMR, where we had David Heyman, Jacob John, the doyens in the field of virology and epidemiology. Where I made a statement. Until recently, I used to talk to my pediatric colleague. Oh, these RSVs, mainly children, is not that common in adults. And that was my experience over years because I can't test everybody with cough and cold coming to me. But when we had recently had an affordable diagnostic, I used to test more. Most my patients, especially IPs with cough and cold and their cancer patients, I started detecting more and more patients. Then I started realizing many of my patients are getting severe pneumonia because of the RSV, because not all of them afforded the very expensive multiplex PCR we used earlier. That used to cost 30,000 rupees. And I can't do that on everybody. And probably because I would have been missing RSV. Now I identify more and more RSV. Now I understand the correctness of the data that is emerging from other countries and even in the country. If you want to know the real extent of the RSV in the country, as Raksha mentioned, we need to do epidemiological studies. If that is not happening at national level, at least we individual hospital start doing the test, generate the data. That will help not only treatment of our patients, not only prevention of outbreak in the hospital, but that will produce a national level correct data. We'll know the extent of the disease, and then we can decide whether we need vaccination. And I am convinced, at least recently, that at least my oncology patients, even adult, need RSV vaccination. I have lost patients, my cancer patients, to RSV, and I'll be more than happy to give RSV vaccine to my cancer patients. I'm not a pediatrician, but I'm sure the situation is similar in young kids.
Yes. With that, sir, you have rightly pointed out the needs exactly, and I think this has been a very fruitful session. We all have came to and contributed an hour to this. We had an amazing discussion, very engaging contribution by all our panelists present here. So I would like to.
Sir said, So in
So,
last 10 months, from 1st January 2024 to 31st of October 2024, we had done around 3,500 upper respiratory multiplex PCRs, and 30 were positive for respiratory syncytial virus. Most of them were adults.
Right. Yeah. It's common.
it's common, and like sir said, he has lost patients because of that, the cancer patients, for that, because we do not have that kind of vaccine. So in terms of getting the test, making more affordable, and the availability of vaccine, these both things are very, very important, not just to treat the RSV, or but so that we can proceed with the further treatment of any other patient, like in terms of cancer. So, with that, we'll be closing our session for the day. So, thank you so much to all the panelists for coming to this panel discussion, making this 1 hour very fruitful and engaging panel. And thank you so much for contributing and sharing your insights and expertise with us, and generating, creating that awareness amongst the general public and the audience. Thank you so much.
Thank you.
Thank you.
Thank you. Thank you.
Thank you.
Thank you.